So
Perfect.
first everyone, thanks for joining Queen's Global Oncology Rounds today. My name is Fabio Moraes. I'm a radiation oncologist and the director for the Global Oncology Program. And it's my pleasure to have today a friend, a colleague, a leader, Dr. Felipe Roitberg. Dr. Roitberg is a medical oncologist. He's a former public health expert with experience at WHO Ukraine and WHO headquarters. He currently serves as the Research, Innovation, and Health Technology Assessment Coordinator at the Brazilian University Hospitals Network. Dr. Rothberg is also a UICC alumni, and he contributes to organizations like IARC and CI. And his aim is to advance cancer research in Brazil and globally. So today we have the honor to have Felipe, Dr. Roitberg speaking to us, and he's going to be talking on National Cancer Control Plans design and implementations, lessons learned on acute disruptions and resource constrained settings. So Felipe, it's our pleasure and honor to have you here today. So the floor is yours.
Fabio, do you hear and listen to me clearly?
Yes.
Okay, great. So for those who doesn't know me, as Fabio did a better introduction than my mom would be able to do. I'm a medical oncologist, and as he said, I have an experience in the field of global oncology. And when I mean the field, that's one of the purpose of this discussion. And feeling that I'm among friends, and friends not only for those who I know, but also for those who I do not know already. I mean, I'll be frank, I'll be honest. So what I've been experienced shifting from the academia to the real world setting, in the sense of how did we shape the National Cancer Control Plan design from what we see in the scratch in the manuscripts to real world life settings. So that's mainly the challenge for today. So I prepared the lecture here, and I will now project it. Fabio, let me see, how can I project it? Just 1 minute, sorry. Share screen. Are you able to see my screen?
It's loading. Yes, now we can see. Yep.
So as an outline for this presentation, I'll discuss National Cancer Control Plans design and implementation, but what are the lessons learned from acute disruptions and resource-constrained settings? Mostly over the past 4 years, we experienced COVID, we experienced the war in Ukraine, we experienced coup in Myanmar, also political instability in Senegal, in Brazil. So everywhere you see flood in Mozambique. So we kind of ignore what and how the role that healthcare resilience can play on cancer, because whenever emergency comes, people tend to invest on emergencies, and somehow cancer is not among the priorities. So how can we shape what the real world practice that we can explore? So agreements, what do they mean in terms of national cancer control plans? What's the NCCP in terms of evidence-based support, practice, and prioritization beyond core components? And here I would like to acknowledge Fabio as one of the main authors of one of the most cited publications for NCCP. I recommend everyone to read. It's the Lancet Oncology. Acute disruptions, where, how, and when. And what about emergency NCD? Do any policymaker consider NCD as emergency? When acute disruptions become chronic, and where do we stand? And human dimension, political commitment, which I think is the most striking and compelling discussion for this talk. And COVID-19 is still a challenge and a neglected challenge. So what about commitment? What is it about? When I went to WHO, the first thing I heard from my previous boss is you should be relevant, otherwise you won't be here again. And the second thing I heard him about mandate. So what's mandate? As the countries, they get together into the World Health Assembly, and then they sign a document whenever they commit themselves to reduce inequalities and to improve healthcare globally. So according to these mandates, which means agreements, formal agreements, the countries committed to improve universal health coverage, the main principle, to leave no one behind. And the two main targets for 2030 is to decrease by 1/3 premature mortality from non-communicable diseases. I like to highlight the word premature mortality, so that for young people, those who are still the productive age. And the other one is to improve access to safe, effective, quality, and affordable essential medicines and vaccines for all. And I don't mean all medicines, I mean, at least the essential medicines, and we should discuss what's essential. And in this regard, national cancer control plans are considered a pillar, where it was also assigned in the mandate. So the country should provide, should promote national cancer control plans, but WHO and the community should support them. So where do you live, gender, ethnic group, or migration status do not determine if you're gonna develop and die of cancer. So this national commitment, as you see here, just like to reinforce, this is the paper, as you see, for the National Cancer Control Plan in Ukraine. It started in 2015. And one of the reasons I've been in Ukraine this year is just to finish this. So can you imagine a National Cancer Control Plan started in 2015 or 16, and by 2023, we're still discussing how to effectively finalize this. You should ask yourself, is it something that happened by chance? No, it happened everywhere. It's not a privilege for Ukraine. So why a cancer control plan takes so long to get designed and published? For those who don't know also, can you try to see NCI last year? They finalized the National Cancer Control Plan from NCI, I mean US, so it's not a privilege for low-income countries. But let's bear in mind that acute disruptions usually affect the less developed countries in terms of fragility of healthcare system and fragmentation. So those who are underprivileged, that it also reflects the socioeconomic gradient, they live worse and less. And this is a graphic that shows about cervical cancer mortality according to age human development index. So clearly see here, those who live in less human developed index regions, they live lesser. So if they are affected by acute disruptions, and by acute disruptions, not only disasters, but political instability that change all the healthcare system policies, also might affect these people. So let's figure out about resilience. Here are pictures of places that I've been, and I've been supporting also. In total, I supported 36 countries, actually 37. Now, if I consider my own country, 38. So in this regard, we see here mostly tragedies related to healthcare disasters, but also conflicts, pandemics, flood, blasts. So let's discuss where in the disruption cycle are we in terms of stages of response. If you see here an horizontal line, it describes the healthcare system performance, assuming that's linear, fine. But then you still have the onset of disruption where the healthcare system should decrease the performance, and you should provide the minimization of disruption during absorb and recover. So you see all these phases, they look clearly defined, but in the real world, it's not that the way. So let's consider the preparedness response. So the first one is to make sure the healthcare system is adequate to support, to endure if acute disruption occurs, and then you have capacity to observe and then start recovery. But mostly this covers much more deep and large if you figure out what happens in low resources settings. So this figure, I wouldn't say it's appropriate. Actually, it's not. It should be the opposite. So I'll start with Ukraine, one of the countries I have the opportunity to go, but also I've been in Poland and Moldova to support the conflict in the region. So when the conflict started by February past year, 5 million refugees just migrated in less than 2 months to Poland, all the countries around, and 7 million internally displaced. Can you imagine 12 to 13 people in 2 or 3 months? Actually, they are not where they used to live anymore. And they didn't ask for that. So if there's no solidarity to accommodate these people, and I don't mean only cancer patients, there's no way these people will receive any kind of healthcare. This is important to know. But what's the amount of cancer patients that used to newly cases in Ukraine per year? It's about 180 cases a year, 80,000 cases a year. So it's a huge volume of people yearly. So can imagine the conflict now has more than 1 year. So if I didn't diagnose, for example, any cancer patient, which is not true, I would pose a risk over 180,000 people, and probably now 300,000 people. So these are the numbers that we should reflect on. So when the conflict started, I've been there in April. I raised my hands and I said, boss, yeah, let me go there. There was a special request. Well, so what's emergency whenever a conflict like that relates to cancer? That was my mom's question. Felipe, why would you go to Ukraine now if everyone is fleeing around? I wouldn't say I would like to be a hero. Surely I'm not. I used to be smart enough to not go as a hero, but something that I should feel that would be necessary. In this regard, let's say that we developed an expertise, not to claim myself as I, but we, that we use to support countries in acute disruptions for Libya, Syria, and other countries like Oman and Yemen for urgent procurement and the value of care assessment. So that's what you see here as a summary of the value chain for health for cancer medicines. So whenever we started figuring out, when I was there in the field, the discussion by assessing that not only to purchase or to procure medicines, but otherwise we're going to get lost on track, how to assess this. In terms of manufacturing, the cancer medicines, they are hard to produce. I don't know how many of you are aware, but they cannot just exchange a medicine from Poland or any surrounding country to Ukraine or to Moldova. Why? Because you cannot produce them in less than 3 months, because all this process requires quality assurance, and there's no stock. Nowhere, there's no stock. So you need to have at least 3 to 6 months of stock to replace it. So there was no way that a solidarity, a global fund solidarity, could support this from a country to another. So it's important to bear in mind, because mostly it's unknown information. Internal marketing, share capacity, as I said, is constrained. Quality assurance is needed. Selection, pricing, reimbursement, as you see here, many of these patients are stage 3 and 4. This is driven because if I want to purchase medicines, what are the shared population that would require cancer medicines, for example? You should estimate and calculate that to forecast the volumes you need for 6 months or 1 year procurement. And also, you should qualify what are the medicines that would fit the best. You could not keep buying the same basket of medicines that they used to buy previous to the conflict. Then every shift procurement suppliers, also see the procurement agency pull it, procure, try to do for 1 year or 6 months interval. And the forecast is hard to define whenever people are migrating. So how many cancer patients are still in the country is a challenge to try to figure out how would they be there. I try to connect with every agency as possible. This data does not exist. So there are lack of suppliers. 7 suppliers were just disrupted during the conflict, and then how to define and how to agree with the medical community about a specific guidelines to be followed is not easy, also in terms of treatment interruption. So these are the findings that I will just shift to accommodate the time that you'll be proposing to my presentation, but mainly as are the main challenges that I cited before in terms of stage shift, migratory flux, treatment interruptions, guidelines needed for prioritization, services availability. And this is a kind of challenge now that we are seeing disruptions in every healthcare system modality, and how to not only propose giving medicines, but if you need to do adjuvant, you need to provide surgery and radiotherapy and medicines. So because if a cancer patient with breast cancer, for example, if we want to do and buy medicines for adjuvant treatment, previously she should have received at least expected, most of the case, I'm not referring here to adjuvant setting, but should receive at least in a timely manner surgery and radiotherapy. Otherwise, it makes no sense to keep buying medicine. So how to define the best scenario for clinical management of these patients also is an important topic for discussion. And as you see here, we're trying to define a list of how to prioritize these medicines according to EML, essential medicines list from WHO, and also other criteria like public health relevance, magnitude of benefit from ESMO MCDS scale, toxicity, capacity to deal with toxicity side effects, because it makes no sense to keep pushing for toxicity that as the physician will reduce it to keep pushing these medicines if they are not able to be seen and treat them effectively, but also safely. And also alternative options and diagnose capacity, second or third line therapy in this list to support prioritization. So here you see, according to a minimum basket, what would be the added cost for this basket. So for the 75 initial medicines proposed, if we add just 12, it's going to increase the total cost by 3%. But if you include this third and the fourth scale, which means that lower value, I don't mean necessarily low value, but the lower value, you're going to increase the cost by 45%. And I'm referring here to a resource constrained setting during a war, a conflict, so the budget just goes away. So important also to discuss services provision, because this will be a challenge for us to understand what is the forecast in need and the added value for cancer medicine as far as the services provision has a focus, not only medicines. I keep pushing the attention for this regard. So these are the value-based selection, savings, resource allocation. What were the deliverables? It's important to know, because we are dialoguing with people that prescribe these medicines. We are dialoguing with stakeholders also. They do not necessarily speak the same language. So it's important whenever you go to the field and you speak their language. I don't mean necessarily their idiom, but their language. You define and refine our capacity to dialogue, you increase trust in the process. And this dialogue for feasible and sustainable service is important to provide in the sense of what is needed at that moment and how to impact the community in a humanitarian setting with funding and purchase of cancer medicines. Let's discuss a little bit about NCCP and National Cancer Control Plan design and health capacity assessment. Again, I'll go and move further to the right direction of this disruption cycle, and then I'll add a few comments in terms of stages of response as proposed initially by OECD, and here my criticism to this. And what about a chronic and heterogeneous situation that's not acute anymore, but it's going to be chronic, like a war that takes 1 year than it was expected to take 2 months or 1 month. So is it the same thing or still have the same? So here, as a typical Brazilian, I was asked to go to Ukraine and accepted. This is the way I used to keep my mental health. We used to play soccer there. I used to be the worst one in the team. But this is to tell you guys that I started engaging with people in the field and those who worked with me. So we're going to be speaking not the same idiom, but the same language. Let's start about the current status of cancer prevalence. This is part of Fabio and Dario's publication. Only 1 out of 4 countries have data to inform decision-making process. 1 out of 10 have a cost, any kind of cost provision in their national cancer control plans. So there's no priorities if you have any condition to support this in a financial and sustainable manner. Limited health system readiness to implement plans, and only 1 out of 14 has any description regarding monitoring the plan for implementation. So how to implement a plan? If 1 out of 10, there's no costing to budgetize this plan, and 1 out of 14 has no way for implementation. That's no randomic monitoring, or not at least previously described a manner to do that. So these are the consequences. More than 80% of the national cancer control plans in low and middle income countries have inappropriate screening. This means that the screening in terms of there's no is not aligned with the capacity to provide the whole care for screening more than the test itself. I mean, test, diagnose, treat, and follow up the patient is not appropriate according to the country readiness and capacity. 90% do not have all medicines on the WHO. Less than 40% of cancer plans are coherent with best practice. So it's a huge numbers that make us afraid. Lack of financing consideration, as I said, 90% of the country has a costing consideration, and the benefit packages are not appropriate. More than 60% of the patients probably suffer from financial harm. In this regard, also, there's a lack of capacity where more than 80% of low-income countries have an insufficient workforce. So we're purchasing expensive medicines, but you're not considering the whole picture of people who would provide them care, of how can I finance that in a sustainable manner. And as you see here in the right part of this slide set, what we can do to improve this in terms of data-driven interventions, prioritization, and forecasting purchase services. So here are 2 situations where I see acute disruption initially and a chronic disruption from acute setting disruption. So you see here the conflict and COVID, where more than 40% of the countries reported disruptions in their healthcare system to provide cancer care. So the pooled funds, they are not so flexible as we would like to. Especially in the settings, there is also a reduction in terms of capacity for the country for investment. So we need to expand and maximize our investment in terms of having wise decisions. So what do we want to do here? We're going to increase new services or complex services? Are we going also to additional improve coverage? I'm going to improve quality and workforce capacity. These also are how they dialogue with this diagram that you see here. Improving coverage is surely the most impactful proposal. So rather considering include a new cancer medicine or a new service in your country, should ask yourself, what's the current coverage for that services? Am I providing cancer care for all, or I'm just increasing the volume of services and not increasing the coverage? This is an important discussion that will maximize in a progressive manner implementation setting. So just a framework. First of all, should provide assessment, appropriate assessment. What we used to have in Ukraine previous to the conflict in a few months is not the same. So we used the previous background in terms of assessment and created assessment tool that could provide a fast track in terms of assessment, because usually assessment takes months to happen, provide this response. So we created a framework that in a few weeks provided the response that we need in a granular manner according to every cancer center. But to this to happen, what's the lesson learned from here? Initially, just for you to know, we sent the cancer centers in their own language. I mean, it's not in English, but Ukrainian surveys. Do any cancer service director want to look bad? If I send Fabio, can you please let me know how's the current situation of cancer center? Do you think Fabio looks worse than the others to the Minister of Health? Does he want to be acknowledged in that way? So we should build up trust. This is important though. What we will do with this information, how we're gonna what we're going to do with this information, how we're going to support them, and especially if we're going to be able not only to speak their idiom, but their language is important. So we hired two consultants that are one surgical oncologist and another clinical oncologist in the field, and starting sensitizing them to what we're going to do. What happens next is the compliance to the surveillance increased a lot, and also the accuracy of this. So this is a lesson learned. If you want to do global health, if you want to do global oncology, please dialogue. I will repeat this message from the beginning to the end. And it's not to describe it. And it's not only making a call, it's speaking their language. And I don't mean necessarily the idiom, but being sure you produce and increase trust, accountability, and improve leadership in the field. So these guys were acknowledged as leaders by their connection with not only WHO, but they're also medical societies. And as you see here, part of the discussion included also by request to improve the medical facilities in the field. And you see here a mismatch between what are the cancer centers able to provide. Most of the cancer centers do not have comprehensive care differently from the high-income countries. You have different spots, as you see here in green, are services availability, and in red dot is no availability, and in black, no data. There's a mismatch between diagnosis, radiotherapy services, surgery services, and chemotherapy provision. And we should also define also the nearest distance to refer the patient. So it's not an easy test. So whenever I was in the field, we had a team where I asked it to have a person that used to work with geolocation to support me in this regard and to make all these calculations and assumptions using computational model to support the decision-making process and the decision process where the facilities should be not only placed, but also improved, and where the patients be replaced. It's not only a standalone discussion, but much more complex to make sure for the resource that we have now that's much lesser, we maximize the results. And here I say space for innovation. And Fabio, you're the one to speak about innovation here, my friend. NCCP design, a framework as I see should be surely decision-making based on evidence-based, but also we should reflect of the current normative guidance from the countries. Criticizing those who producing this does not build up trust, but the opposite is true. Let's acknowledge what is there. Let's try to connect the dots. Let's see how the best evidence and best literature can support also reaching the targets that are defined by WHO or other institutions that care about metrics and about goals and targets. Let's define and refine goals, but also let's prioritize to make resource appropriate benefit packages. So here are the main or the core domains for an NCCP, as you see here. prevention, governance, early detection. So when I use to support countries designing national cancer control plans, these are the main or the core dimensions used to be reflected. But you can just cite them and do not develop or to articulate them between your action plan or your NCD plan. So not only acknowledging what is there, but ensuring the normative guidance that is produced or is being produced is aligned. So part of the discussion is not only acknowledging if it is there, it's how it's quantitatively described, if resource appropriate, if has any source of prioritization, and if it's aligned. This is a challenge for us to make sure we are defining something that will be useful and potentially implemented. And we have tools now to refine this evidence-based decision. As you see here, this is a forecast from a country that requested us to discuss doing screening. It's easy to propose, oh, let's do breast cancer screening, but what are the targets that you want to reach? If you look at the WHO targets you see here, it's improve the early disease detection, which means more than 60% stage 1 and 2, time to initiate treatment less than 60 days, and also treatment coverage by 90% in 2030. So let's try to ensure by using a computational model, we can try to project it. That's what we did by a model that we created during the period was in WHO. And as you see here, if you compare the status quo, the current status, or only early detection, or if you add screening, what's the difference in a projection in a few years? So what you see here is the additional value of improving detection by mammography in the mammography-led scenario, or only improving CBE. This means that if you start in a resource-appropriate manner, improving early detection in the sense that when the system is optimized to refer the patient, to treat the patient timely and with quality, then the additional benefit of screening with mammogram or ultrasound, if someone proposed that, I'm not telling that, but if someone in the countries propose it, you have additional value. So as you see here, mammogram-led scenario increased by 6% the difference between early detection. So if you don't have everything in place, let's start at least considering a progressive manner this dialogue. You're going to spend a more wisely your resources, especially in resource-constrained settings, as you see here. And it's important to acknowledge what are the strengths, what are the weaknesses, and what are the remaining challenges for the National Cancer Control Plan. Here you see some publications that support this discussion, and we acknowledge it that the Cancer Control Plan was goal-oriented, designed by experts in the field. Majority of the core domains were covered, and especially, please, again, I'll repeat this every time, political commitment is high. If you have political commitment, you have a way to go. And this is about dialogue, it's about building up trust, it's about speaking language, it's about having appropriateness of what is expected from us, not only cancer medicines, but cancer medicines as a component of services provision. This is important for you to know. If you want to dialogue with government bodies, it's important not only to address the cancer medicines, but ensure in this discussion you are aligning, and then they see that the discussion is appropriate. Let's push the agenda because I think the time. But back to acute disruptions. What you see here is a flood in Mozambique. It happened in 2000. And what happened is that a tropical cyclone killed more than 2 million people. I'm sorry, killed more than 700 people. 2 million people affected. What are the consequences also? That the economic rate or economic growth rate declined from 12 to 7% after the floods. This means that the capacity to invest in health has been not only reduced, but shifted to the acute response to this emergency in terms of providing care for those infectious diseases related to this flood or to reconstruction of the country. But even though this is still a challenge, especially infectious disease in Mozambique, they took the decision to invest in cancer. And you see here, years later, they started designing their national cancer control plan, even if they are still a low-income country. So what we did there is aligning essential medicines list, national cancer control plan, and strategic plan, as I told before. As you see here, we could discuss and finalize here the process. There is a country request, initial dialogue, political engagement, and then the NCCP review. So we might say we're done, but then there's the rest of this discussion. We should make appropriate resource decisions. So after revising the National Cancer Control Plan, what about revisiting the capacity for that plan in terms of readiness to be adopted? So assessment and data validation is important. Discuss prioritization, discuss validation, and the health and economic impact. So a decision might be made based on priorities, and you might see the benefit of investing in cancer. This is important. It's not cost, it's investment. Whenever you give the sense of health impact and economic impact, then you have this different discussion with Logan here about investment, and then refining the deliverables that you want to address. And so there's a process here from feasibility assessment scenarios when we want to improve coverage. As I said, here's as an exercise that we started at 1% increase by year, and focusing on women and children cancers. And then a healthcare system planning capacity, we revise it, and then we define the workforce as a bottleneck, also in many countries, and then we generated a business model. Just like to give an example, because I think for those who are here want to hear concrete examples. There was a proposal for 2 mammogram machines for every general hospital, provincial and central. So we forecast the prices and the volume. And what we found is that in terms of impact on coverage by exceeding 2% a year, this proposal would exceed what is necessary to deliver the proposed package of cancer service. Fabio did a quite nice review in Brazil for radiotherapy machines when they were bought without appropriate analysis. So they were not currently implemented. Some regions, they could exceed the need, and some regions that should receive or not receive it. So a more appropriate decision should be made. Not only you should buy mammogram machines, but where they should be placed and what the volume. This is important for us to know. And also by increasing the mammogram machines, you by 1% a year, you would have sufficient workforce to proceed surgery, to proceed with diagnosis. But if you go for 2% a year, then that would be insufficient, the coverage, you won't increase the services. So we should focus on the workforce increment and to a different model of curriculum or competency-based assessment for the patients. Otherwise, you wouldn't reach your goals by increasing 2% a year the services provision, but only a few tests, but not the continuum of care. Fund is necessary to provide comprehensive care to population. Here's a forecast comparing early diagnosis with status quo, with screen, but then projecting the costs. But here I'd like to rephrase and reinforce the discussion about how relevant is to build up trust, to build up ownership, engagement, accountability in the leadership model. What you see here is a real world, I wouldn't say real world, it's a picture from a conference where I asked the person in charge for the National Cancer Control Plan to interact with the national experts. I mean, to create specific groups to discuss prevention, to discuss the early diagnosis, to discuss treatment, to discuss burden of disease. So not only the oncologists, but including statisticians, radio-oncologists, including palliative care physicians, nurses. So we have here a more comprehensive assessment, and then we can go beyond the clinical trials that would support the National Cancer Control Plan. That's what usually happens when you put only physicians in this discussion. So as you see here, we validated all this data on burden of disease to health program, what we call pacotes in Portuguese would be the benefit package, and unit cost, salaries, medicines, equipments. What's the other way to rephrase this? There's a constructive and continuous feedback. What people doesn't want is that you go there, you do the surveillance, you do your publication, but you don't come back to tell them how this could support them. So we should interact with community through an open dialogue. Language and idiom also reflects a lot of this engagement. I'm Portuguese speaker, and this is from Mozambique. They also speak Portuguese. Just to reflect, the previous dialogues we used to have was in English. And what happened since we started dialoguing in Portuguese, it increased a lot the capacity to interact and provide inputs. So not only language, but idiom somehow is important. It's important for you to interact. That's the idea, build up trust. What about build up trust. So I did this, and I go to World Health Assembly or World Health Congress, and I speak on their behalf. No, they should be the one acknowledged for this process. So this lady that you see here speaking is the Mozambican National Cancer Control Plan representative. She is the one speaking about the process, not the four of us around her. So empowering those in the field is important to build up leadership, because they are the true heroes. They are the ones who are still struggling with the healthcare system whenever my publication or my time is out. So they will be the one to be connecting with the funders. They will be the one to be connecting with the other agencies. So this is the way also to have a more sustainable manner process for the NCCP, not only design, but implementation. So please, let's acknowledge people who are in the field. And just to finalize this as a provocative discussion, COVID-19 pandemic is over, in the sense of now we see a spark of cases rising again, and we should be careful, but it has been declared over as a pandemic. Are the healthcare system disruptions over? Are tailored mitigation strategies in place? Did we map them in our settings? By the end of 2021, more than 40% of the countries still reflected and they referred disruptions in the cancer care. And you see here more than 50% in terms of immunization. Here includes HPV vaccines, where the coverage dropped a lot. So all these disruptions, including not only the healthcare system, but also the patient-related in the sense of misinformation, the value chain for shipment, programmatic shifts, reduced revenues, they are still there. So what are we doing for COVID? We spoke a lot about COVID, but what did we effectively do to support these countries, in the sense of the NCDs are still suffering? Going to be a wave of deaths related to these disruptions that we had one day we acknowledged, but we didn't move through this. So just to finalize my talk here about the privilege that I had to be in these countries, to live in some countries like Ukraine, here to see myself in a shelter with my dear colleague there, working during a night shift there to get rid of the bombs and keep the mental health, or interacting with in Kenya or stakeholders, but also with those in the field. For those who doesn't know that what you see there in the hands of the person with like a nut is a nut. So by the very first time I seen a nut, and Reddit said, no, you should get rid of a nut, I started understanding why they consume that and how they consume that. So it's quite important to interact with these people, to go to the field, to see their smiles, not only to interact with the Minister of Health, as you see here in the pictures, but with those who are there in these countries. So we should act global, but we should connect local with these people, surely. And to finalize here, my last comment is that I would like to acknowledge the Queen's University, Fabio and dear colleagues. Fabio, I believe you're not in this picture, my friend. I'm so sorry, the one that I found here. I'll try next time to include your tag here. But for those who doesn't know, Fabio is one of those who conceptualized the CSO, the Common Sense of Oncology in Queen's University, who is leading a way that we reorient the oncology community to address global oncology, in a sense to provide care, quality care, but also be mindful of what really matters to the patient. And here, I'd like also to advertise a position that this guy is open in Queen's University for fellowship for those interested and to apply or to support the application process, because I really believe on these people that are here hugging and I have the opportunity to interact. Thanks a lot for this opportunity. It's over.
Thank you, Felipe. That was an amazing and very inspiring talk. I do like want to echo what you said. Dialogue and connecting with people, it's the way to move forward. Sometimes we focus a lot on our research experience, our papers, but without dialogue, without engaging with people, we cannot move forward. So I'll open the floor for questions. So if anyone has any questions or anyone wants to send in any comments to Dr. Roitberg, feel free to do so. I will start. You got some like very good experience from your time at WHO and then your time on this expert missions, and now you're back to Brazil and you're kind of like managing like a big portfolio on research and innovation. What have you learned on the last couple of years that you think is going to be instrumental to improve research, innovation, and access to care in Brazil?
Fabio, this is the most compelling question I've heard recently. Thanks a lot for pushing me against the wall. So what I would tell you is the following. No previous experience could prepare me 100% to what I've been facing here. So cultural, politics, and especially policy, not only politics, plays a major role. The legal framework of Brazil is unique, like is unique in Nepal, is unique in Morocco, is unique in every place you might see. So having the current fiscal environment, the legal framework, and regulatory normative guidance is just starting for this, but it's so specific. And what I've been doing now, just to give a sense, one of the main challenges is to deliver a policy, the first policy on research, innovation, and healthcare system assessment. What happens is that within my team, I should build a trust because I replace another person, and there's a process. Keep them engaged, motivated, and inspired is not easy. Dialogue the same language with technicians whenever you are here in position is not easy also, because even though they're technicians, we should put some code of political dimension and intersectorial connection to make a plan effectively operational, not only a document over the desk. So these are agreements that should be connected to ensure whenever the plan is out, someone will fund them and push this agenda forward. Is not easy. There's a lot of discussions to internally in the institution, but externally in the other ministries for this plan to be accepted, to be oriented, and to be funded. And that's my challenge here. Not only having funds, but ensuring people who have this fund would allocate this because they see a value. So that's my answer to your question. I've been learned a lot about the dialogue, and whenever I got the plan on my hands, what I saw, there was no political dimension included in this plan that would push this forward. So I had to put this on hold and rebuild a few components of this plan with my team now. Can you believe if they were happy because they were with the plan almost ready to go? And I said, no, please, let's put this on hold. So I put myself on fire, I'll say it this way. But on the other side of the coin, that's what these discussions told me. How to improve dialogue, how to improve communication, how to find OKRs, objective key results. For those who doesn't know, Google uses that it's a revolutionary OKRs. So how can you include OKRs and how people would commit with them? It's hard. Can you imagine? Do you want to ask a government to commit with key results? It's not easy. So that's my answer to your question.
No, thank you. It's very nice to hear and learn from you. So there are some comments on the chat. So people are just like congratulating you for the great talk, for the wonderful work, and what you have been sharing here. Actually, this is Dr. Brooke Wilson. She's one of my colleagues here, and she's one of the leaders on CSO, like Common Sense Oncology, from our institution. So I'm very happy that we have her here. More earlier today, we got a question asking if you could share the slides and then share your contact information for further communication and for future opportunities. Is that okay for you?
So I'm writing down my personal email and my email, and I'll share with you the slide set. So the email is in the chat now.
Sounds
and
great.
I'll share with you, Fabio, later on the
presentation. Thank you. I have the floor open. Anyone for questions? Anyone for comments? Oh, there's a question there. So please go ahead.
Hi, Felipe. How are you doing? I have one question. I don't know, are you hearing me okay? No? Okay. My question is, whatever you plan and you put into action is going to bear fruits in several years from now. How do you factor in the possible changes in the political landscape that can come very quickly in Brazil and in other countries?
My friend, this is a 1 billion question. I think you and Fabio are trying to challenge yourselves to see who has the most difficult I'll tell you there's no clear answer to that, my dear colleague Jose. Instability happens everywhere, and the political instability plays a major role for this, you know that. And this is not only in Brazil, but also in Europe. As you see, I want to speak about right wing or left wing, but it changes considerably. And the agendas change also in some. Like we're going to provide universal healthcare for everyone. It's one part of the agenda. And no, let's let people fund themselves is another part of this agenda. The migration agenda in Europe, let's not discuss only low and medium countries. So those who migrate to Europe, they will have access to healthcare. We don't know that because this goes through another discussion about sovereignty for these countries. So being straightforward to your point, there's no way to ensure that. What we want to try to do is the following. I got the policy for research innovation. And when I read that, I didn't find components that would make a kind of a hook, let me tell this way, with not a government policy, but a state policy in the sense of that would endure for a longer period. Partnerships that I'm trying to build here, involvement with the community also is important component, because if you don't have the community involved or intersectorial agreement that would kind of build up resilience to this proposal, it can clearly lose the scope or do not be implemented, as you said. So I think these are the main challenges. Also, let's remember that funding is not because I have the budget there. I have the budgetization, the cancer plan. I'll have enough funds, because economic instability also occurs all the time. And when it happens, they try to disincentivize the investments in health, and specifically in areas like cancer. So whenever you include the community and come up with health as a value, healthcare as a value, and cancer care as a value, I think the opportunities to decrease the investment is lower. And I speak for countries like France or your country, for example, it's much harder now to disinvest in areas like healthcare than perhaps in decades ago, because you have the sense of the value of that. That's my point. So interacting with the community and making sure there's a hook in this plans that would activate the intersectoral agreement.
Oh, sounds good. It's a very good discussion in a very, as you said, challenging and difficult topic. That's something that we cannot most of the times control or have a accurate plan for it. So I'm hearing any other questions, any other comments? Anyone willing to join the debate? I have another question.
May I
Yeah, go
provoke?
ahead.
I'm sorry.
Yeah,
we have a dear colleague that I value a lot his current role in cancer care and the discussion, which is Khalid. And Khalid, I believe he experienced also in his country some source of acute disruptions, when I mean related to natural disaster. So I don't know how much he has been involved in with this discussion, but if not now, because he's probably shy or not, I would love to further discuss with everyone here in this call about this. Hey, my friend.
Yeah, do you hear me well?
I hear you. I'm sorry, Fabio.
Yeah. Can I have one question? Okay, thanks. Thanks, Felipe and Fabio, for this great talk. It's long awaited because unfortunately issues related to global oncology are less discussed globally. So this is well appreciated from you. In fact, yeah, I totally agree. We are facing similar challenges related to managing patients with cancer during disasters. We faced recently the Morocco earthquake. So we had issues to help patient with cancer who lives in rural area, because the earthquake was in mountains, in rural areas, and patients with cancer could not join the oncology team in university hospitals to take their chemotherapy, for example. So this was really challenging for us, because we are no longer seeing our patients coming from these regions in our daily practice, unfortunately. So for this reason, we wrote a paper for Lancet, and it will be published today at midnight, I guess, where we asked the oncology community to act as fast as possible to adapt international cancer guidelines, so we can prepare general practitioner to do like task shifting, so they can maybe help these patients in rural areas to have their drugs and take care of their emergencies. So yeah, that's a challenging issue. Unfortunately, we need to adapt international guidelines so general practitioners can help, maybe to simplify them. I don't know how can we do that. Maybe Felipe can give me some ideas how to attract international cancer societies like the ASCO, the ESMO, so they can prepare guidelines for emergency situations like in the Ukraine, like in Sudan conflict, like the floods in Pakistan and our earthquake in Morocco. So what do you think, Felipe?
So Khalid, first of all, thanks a lot for interacting with us. I think it's a plus for us to have you on board, especially so because being so active and really shaping the difference in your country, you inspire all of us. So thank you. Pertaining to your question, I think the first step is to ensure you have a proper assessment, not only for cancer medicines, but the whole services provision, as I mentioned before, to ensure we forecast the volume of patients, but also the volume of services to be provisioned, and then we have a resource appropriate proposal. Because clinical guidelines should be part of the clinical management, and people usually in medical oncology, we tend to use only the medical oncologist part of that, but we do not include radio oncologists. I'm not speaking from you, my friend, please, I'm speaking generally, okay? But so this is important to know, can we forecast the volumes of services in need, considering now the workforce currently in the country, the healthcare system capacity to provide care, but also the services provision that is effectively connected. I think this is important for us to start. Will be the starting point for the discussion, because otherwise any source of resource appropriate proposal for a clinical guideline not associated with the clinical management of the whole continuum of care would surely not reflect on the result that we need. I don't want to make this more complex, but I'd like just to reflect with you about the findings of how to maximize the investments and return for investments. I would be so happy to discuss with you, the community, whenever needed. And I'm sure many of us here would support this also. And if you need the connection, we surely can make this happen, and I think that we would make this work.
Great. I will contact you soon about this. Thanks for a great talk.
My pleasure.
Oh, I see Team Hannah is jumping in. Go ahead, Tim.
Thank you, Felipe, for this incredible talk. It's really nice to hear about your experiences and to hear your wisdom. In Ontario, we are thinking a lot about quality improvement of the provincial cancer program. And one of the topics that has been talked about quite a lot is waiting times, but not just little pieces of the waiting time, but the integrated waiting time. So how long does someone wait from the first time they contact the healthcare system to when they start their treatment? And that involves a lot of different players. It can involve the surgeons, the imaging departments, the radiation oncologists, primary care, so many people. I'm just curious if you have any thoughts about how to break down silos between these different groups. They all have their own leaders and managers, and they have to work together to get that that waiting time shortened. And I think a lot of the work you've talked about, it involves a lot of different groups of people working together. So I'm just curious if you have any thoughts.
Thanks, Hannah. Having a question from you is really a privilege to me. I don't know, it's more a responsibility or a privilege. I don't know how to balance this, but mixed feelings at the moment. If I'm not wrong, you're the one that produced a nice paper according to the impact of delays on treatment. Am I correct?
Yes, that's right.
I recall your paper. It's a really nice one. For those who didn't read, I would advertise you to start reading his paper because it's really insightful. And that's why probably you're coming with this question. So how to integrate services in a quality and timely manner. And there's so many pieces to put in place. So there's also the capacity of the patient in terms of literacy and to accommodate not only literacy, but here their own beliefs, their fears. because sometimes the patient just do not show up. I don't know in your culture, how does it shape? And in Brazil, for example, Fabio is a Brazilian by heart, now a Canadian by experience, and I'm sure he recalls that patients somehow they don't come in, also especially in several countries in Africa or Middle East, because of some beliefs regarding to, oh, if I show up, then I will discover a disease. If I show up now, so there's fear. There's so many aspects related to the patient perspective, to the physician perspective, the healthcare system pathways, the healthcare system. So it's a really complex one. I don't know if I have the chance to see the IR handbooks. The IR handbooks, they have a specific chapters related to, for example, to screening uptake. I'll just use this as a reference. And they address several points in this pathway that's not only transversal, but there are some vertical verticalities related to that. It's a true challenge to make things happen as we're gonna like that to happen. I don't think we're going to address 100%, but I think I agree with you to ensure we want to address this. Just a last point, artificial intelligence and gadgets now have been mapping patients through the pathway of care. I think that could provide really insightful inputs for us to put in the papers and to dialogue with the stakeholders and the policymakers. I believe exposing data, exposing information, and more granular, discussing this with those from human sciences like anthropologists could improve a lot of our capacity. That would be my guess to your point. I don't expect to have an answer to such complex question, but that would be my guess as a starting point for the discussion. Over.
Thank you.
Okay. I think we are getting to 5 p.m. here and 6 p.m. And we have agreed with a 1 hour discussion. So anyone else, any further final comments, final points? Felipe, if we don't hear any further comments, I would like to thank you for your time and for sharing your insights and your knowledge here with us. It was really appreciated, and it was a great learning experience for me, and I'm sure for everybody here. So before we finish, I'll give you the last word. So if you want to share some words of wisdom or inspiration or recommend anything as a book or something, we'll be happy to get some advice from you.
So I'd like to start just acknowledging those who find out time. And your agenda, I know, is quite busy. So having you on board is a real and true privilege to me. And the real thing that I heard when I started from my mentor and previous boss, Andrea Bavi, is that you should serve people whenever they need and whenever they are. So that put me surely in a mental stress, but also that gave me nice inputs of how I believe global health should be shaped. So I would like to thank you for the opportunity to serve you. And I hope the discussion was insightful and useful to you. That's my main goal. And I'd like to thank you deeply from the deep of my heart and the bottom of my heart. Thank you so much, Fabio, for the opportunity. And thank you, Queen's University. And thank you all who attended to this discussion.
Okay, thank you. Thanks, everyone. It was a great evening. So have a great evening. Take care, everyone. Thank you.